Hello, everyone. I'm Daniel Bowler. I use he, him pronouns, and I'm the Development Director for the American Lung Association in Rhode Island and a member of the Diversity, Equity, and Inclusion Council. Welcome to our educational webinar, Transgender Cultural Fluency and LGBTQ+ Lung Health Disparities. Please enter your questions in the chat box, and we'll get to as many as we can at the end of the presentation. I'm pleased to be joined by some of my colleagues from the American Lung Association, as well as two experts, Adrien Lawyer and Dr. Jamie Garfield. Before we jump into our speakers' presentations, I'd like to turn it over to Harold Wimmer, National President and CEO of the American Lung Association, for opening remarks. Harold?
All right, thank you, Danny. And I also use he, him as my preferred pronouns. And I'd like to thank all of you for joining us for today's webinar that is going to be focused on transgender cultural fluency and LGBTQ+ lung health disparities. As the nation's longest standing public health organization, the American Lung Association has an extensive history of health promotion and advocacy work to reduce health disparities, both raising awareness of disparities and taking action to address them. In our work to improve the lung health of Americans, we want to reach all Americans, but especially those most vulnerable. As you know, today's webinar is on the disparities faced by the LGBTQ+ community. Our guest speakers will discuss how a general lack of understanding and awareness about LGBTQ+ communities, particularly the transgender community, has led to negative impacts on the lung health status of LGBTQ+ Americans. Our guest speakers will discuss these lung health disparities and why collecting accurate data is so important. Next slide, please. The webinar is a part of a series of activities and resources the Lung Association is highlighting in honor of LGBTQ+ Pride Month, which takes place every June and has become a global celebration of the diversity, accomplishments, and trailblazers of the LGBTQ+ community. In addition to this webinar, we have collaborated with our National Diversity, Equity, and Inclusion Council to create many additional resources and features focused on the LGBTQ+ community. I encourage you to explore these resources at lung.org/diversity. I would now like to turn it back to Danny. Danny?
Thank you, Harold. As Harold noted, members of the LGBTQ+ community have faced a history of oppression and discrimination that directly translates to disproportionate health risks. This includes having a greater risk of substance abuse and mental health issues, as well as higher rates of tobacco use in comparison to the heterosexual cisgender community. Big tobacco was one of the first major consumer industries to target the LGBTQ+ community, a group that has been largely ignored by mainstream advertising. Discriminatory tactics that normalize smoking and linked the LGBTQ+ community to tobacco use have benefited the tobacco industry while leading to higher smoking rates among LGBTQ+ populations. Currently, about 1 in 5 lesbian, gay, and bisexual adults smoke cigarettes, compared to about 1 in 7 heterosexual straight adults. When looking at transgender adults, the percentage of cigarette smokers is 35% higher than that of straight adults. A 2019 CDC Youth Risk Behavior Survey saw that over 10% of lesbian, gay, or bisexual high school students smoke cigarettes, which is more than twice the percentage of their straight peers. The higher prevalence of tobacco use makes it even more essential to raise lung cancer awareness among LGBTQ+ communities, and lung cancer is the #1 cancer killer. While anyone with lungs can get lung cancer, smoking is a main cause of both small cell and non-small cell lung cancer, contributing to 80% and 90% of lung cancer deaths in women and men, respectively. As the trusted champion of lung health, the American Lung Association strives for a world free from lung disease that includes our year-round commitment to reducing health disparities faced by the LGBTQ community. With that, I'd like to welcome our moderator for today, Will Rucker, who will walk us through the rest of today's webinar.
Thank you. Hello, everyone, and thank you for joining today's webinar. My name is Will Rucker. My pronouns are he, him. It is a privilege to serve as your moderator today. I am the Division Director of Health Promotions for the American Lung Association's Western Division. In this role, I oversee all of our health promotions activities and programs throughout our Western Division. This includes program promotion and implementation, grant writing, oversight and management, and one of my favorite responsibilities, partnership development. I am thrilled to facilitate this webinar today, and now I have the pleasure of introducing today's phenomenal guest speakers. Speaking first is Adrien Lawyer, Executive Director and co-founder of the Transgender Resource Center of New Mexico. Next is Dr. Jamie Garfield. She is an Associate Professor of Clinical Thoracic Medicine and Surgery at the Temple Lung Center of Temple University. Thank you again to all of our attendees. I invite you to submit questions in the Q&A box, and at the conclusion of both speakers' presentations, I will ask them your questions. Adrien, Dr. Garfield, we are so excited to have you both here. With that, I'll turn it over to Adrien for the transgender cultural fluency portion of today's presentation. Over to you, Adrien.
Star 61 to unmute, Adrien.
Oh, great. Can you hear me now? It says I'm not muted.
Yes, you're coming in loud and clear.
Okay, fantastic. All right, I'm so sorry that I'm here by phone, but I'm able to see the screen so I can see where we are with my slides. And I'm really happy to be here with y'all. Sorry for the tech hassle today with me. All right, so let's move to the next slide. And I've got a little delay, I think. I'm so sorry. Okay, so the next slide is a little bit about my organization. I am the Executive Director and the co-founder of the Transgender Resource Center of New Mexico. We began in 2008, and we're a statewide organization that does direct services, advocacy, and education for trans and non-binary people, as well as our families and loved ones. Next slide. My name's Adrien Lawyer, and I use he pronouns. You can see a little bit about me up here. My colleague made this slide. It's some funny things to list about me, but yeah, I started being a bird feeder and bird watcher during the pandemic. I wonder if some other folks in the room did too. I have a 16-year-old kiddo. I play in a little country band, and mainly I work to help improve safety and access for trans and non-binary people throughout our state. Next slide. So we're talking about LGBTQ folks today and lung health disparities. So we just, are going to run down kind of what these letters mean, what this acronym stands for, because that's a lot of letters, and I think, a lot of people know these things, but there can still be some confusion about it. So let's go ahead and go to the next slide. So L stands for lesbian, G stands for gay, B is bisexual, T is transgender, Q often stands for the word queer, which is a reclaimed term. So that's a derogatory word, sometimes a really violent word that folks within the community have tried to take the power back from by using that word to talk about ourselves. So the word queer is kind of a dicey word. It's a little bit more of an in-group term, but that's often what the Q stands for in the acronym. It can also stand for questioning. These days we're seeing I for intersex people, which we're going to talk about in just a sec. And A can stand for a few different things, including asexual or ally. A lot of people are putting the plus on the end nowadays just to include folks whose letters are not yet in this list, but really who belong in the group overall. Okay, next slide. So for us, when we do trans education, and we find that in general, people tend to know a little bit more about gay and lesbian folks these days than they do about trans and non-binary people. And that's just the way where we are in history right now. The trans communities are about 30 years, in my opinion, behind the lesbian and gay communities in terms of things like legal protections, cultural representation, societal acceptance and understanding. And so we really need to start then by trying to parse out some ideas that have been really conflated in our culture. So for us, the first of these ideas is what we would call your designated sex at birth. And that just means the genitals you were born with and what category that landed you in. Because we designate the sex of a newborn baby just based strictly on their external genitalia. So that's not really biological sex, which would include more other complex factors like chromosomes, hormones, gonads, right? There's a lot of different things that comprise our biological sex. But our designated sex is simple. It's just based on the single criterion of what type of genitals you have, how they look, and which category that puts you in. And we say designated because it just sort of describes the process generally, right? The adults who are attending a birth aren't trying to hurt anybody. They just look at the baby's body. They write down what they see on the birth certificate. So we think of this as really just a sex designation that occurs very soon after birth and is based on the genitalia. Now, even when we talk about biological sex, there's more variance than we often think. Go ahead and go to the next slide. Intersex people are folks that have some kind of biological or physiological variation that causes their body not to fit into our typical definitions of male or female. So this can be, this can mean things like ambiguous genitalia, which means that the baby's genitals are sort of in between the two typical types. But this can also mean things as subtle as atypical chromosomes. So it is possible to have an intersex variation and actually live your whole life without knowing that about yourself. So let me let some intersex people just speak for just a couple of minutes because I'm not intersex to my knowledge. So I really want you to hear directly from some intersex folks. So the next slide should be a video. Let's launch that video.
Raise your hands if you have testes. I'm Pigeon.
I'm Alice.
I'm Emily.
I'm Cypher.
And we are Intersexy.
Intersex describes a person who doesn't fit the typical definition of male or female.
I have XY chromosomes, but typical female genitalia.
I'm a girl who has testes and XY chromosomes.
I identify as a queer, gender nonconforming intersex person.
I identify as a Black intersex man.
Intersex is not new. It's been around since the beginning of human existence. I mean, there's probably even intersex dinosaurs, if you think about it.
Transgender has to deal with your gender identity, whereas intersex has to deal with your biological characteristics.
Often, intersex people get surgeries that they don't want, and transgender people have to fight for surgeries that they do want. They gave my mom the excuse that the internal testes were cancerous, that I would develop cancer.
They didn't even come up with an excuse, basically, in terms of a health-related reason. They instead just said it was about the appearance.
A lot of doctors are very uncomfortable with the idea that I have testes, and they're still trying to get them removed, but I'm perfectly healthy and there's nothing wrong with them.
They did a surgery to remove my testes and told my parents to take me home and just raise me as a girl, and I didn't find out about it myself until I was 12.
There aren't a lot of options, or medical providers don't explore other options. My mom would put me in dresses and she would be like, "Oh, aren't you so cute and you're so pretty?" And I would be like, "No, this is horrible." I was put on hormonal treatment, which consisted of estrogen and progesterone. I just wanted to belong. I wanted to fit in. I didn't want to be different. So even though I knew something felt amiss, I conformed. He was very condescending. He was like, you intersex activists don't know what you're talking about.
It's difficult for intersex people to find each other because from an early age we're told not to talk about our bodies.
I did feel like I was the only one.
My doctors always told me there was nobody else like me, and so it just perpetuates a vicious cycle of shame and stigma that we can't break out of. I would tell another intersex person that you are worthy, you are lovable.
Your body is beautiful, you're beautiful.
Intersex people don't need to be fixed. There's nothing wrong with them.
I know you feel like you might not be able to get through this. I know you might have really dark thoughts, but I want you to know that meeting other intersex people and finding a community or a support group can be one of the most important aspects in your healing process. And we're out there, we're out here, we're here. And I just hope you can find us.
Great. Okay, so let's go to the next slide. And so for us, when we talk about biological sex, that is a separate thing from gender. And in our culture, we have really conflated these things, right? The fact that we think sex and gender are the same shows up in a million places. It shows up in the fact that the words sex and gender are used interchangeably on forms a lot of times. Some identity documents list your sex designation and others are listing your gender marker, but really they're trying to list the same thing, right? So when we do this training, when we do our expanded training about trans folks, we offer a 90-minute to 2-hour training called Transgender Cultural Fluency, which if you're interested in at all, you're very welcome to contact me. We'd love to do that for you. So when we do that training, we really expand on all of these concepts. And one of our main things that we're trying to do is separate sex and gender in people's minds. And we know that they can't be one trait because people like me exist and I'm a transgender man. So when I was born, the doctors and nurses at the hospital said, it's a girl, yay. But by the time I was 2 or 3 years old, I already knew that I was a boy. It's one of the earliest things that I knew to be true about myself. And that's my gender. That's just your own deeply felt internal sense of being a man, a woman, or a non-binary person. And it is actually very typical to know this at a young age. Even the American Academy of Pediatrics has released a statement saying that trans kids know their gender between the ages of 3 and 5 in just the same way that non-trans kids do. So they are saying, the pediatricians of America are saying that children pretty much can tell us whether they're a boy or a girl by the time they turn 5. Now, we know that there are trans people who don't know by the age of 5, but the vast majority of us do. If you talk to trans folks, many of us will tell you that this is one of the earliest things that we knew about ourselves was our internal gender. And gender and sex have to be separate because there are people for whom they don't match. So I actually think of sex and gender more like hair color and eye color, right? They match for a lot of folks, but for some of us, they don't. And that's totally okay. Just the way most people have brown hair and brown eyes, but some people don't, and that's okay, right? Okay, next slide. The word transgender is an umbrella term that we define to mean any person whose gender does not match the sex they were designated at birth. That's all it means. It's just meant to be a really simple term that is an umbrella to be able to hold a lot of different people. So you'll notice that our definition does not include any kind of medical treatment, and our definition does not include words like opposite, because this is actually not a binary system, even though that's also something we've grown up all being taught. Actually, we know that non-binary people have always existed and do exist now. So for us, we just say that trans means anyone whose gender differs from the sex they were designated at birth. Next slide. Those of us who do seek out medical treatment typically have what is called gender dysphoria. And that is the current diagnostic code for trans folks. And it really just describes the discomfort that some of us feel when our bodies are not congruent with our gender and the need to do something about it, essentially. And this is housed in the psychiatric diagnostic manual, but it is not listed as a mental disorder or a mental illness of any kind. So it's really important to understand that this is really just a way that we are able to obtain the medical treatment that we need. And for many of us, it feels like a pretty accurate description of how it felt. Like I know y'all can't see me, I'm sorry, but I have had medical treatment. I've been taking hormones for a long time, for 16 years. I had surgery on my chest as well. And those things were really important for me because I absolutely struggled with gender dysphoria. And I was not able to take good care of my body. I did not have a caring, loving relationship to my body. So for me, when I read the DSM entry for gender dysphoria, I'm not upset. I actually relate to it. It feels like it very well describes what I went through. But it's really important to understand that there are some trans and non-binary people who have dysphoria and want medical treatment. And there are some trans and non-binary people who do not have dysphoria. So we definitely don't want to assume that all trans folks have dysphoria or that all non-binary folks don't have dysphoria. Under this umbrella, it's just very personal and very individual who feels a need for any kind of medical treatment or who feels, challenges or struggles with their body. Next slide.
Adrien, we have about 3 for your presentation remaining.
Okay, sounds great. So those of us who do get treatment, this is some of the stuff that we undergo. It's just a sampling. There's more things that would be included in medical treatment for trans and non-binary folks, but these are kind of the main areas. Next slide is just my journey through time. I'm happy that y'all can see this since you can't see me. So you can see when I was little, I was very much what they called a tomboy, right? And then the kind of bottom 3 pictures are once I started testosterone. So that's me going through my male puberty in my 30s. Did you know that? When you go on hormone replacement therapy, you actually go back through puberty. So that was really fun. Okay, next slide. Non-binary folks are people who do not conceive of themselves as a man or a woman, but it can mean a lot of different things. Gender fluid people experience their gender as changing over time, where agender folks feel that they have no gender at all. So non-binary is also an umbrella term that means not male and not female, but it can mean different things. Next slide. Cisgender is the value-neutral term that has been created to talk about people who are not transgender. So most of y'all in the room today, statistically speaking, are cisgender. Probably at least 96% of the folks in here are cisgender, and that's awesome, right? That means you're not trans. And the reason we need this word is because we can't use the word normal instead. And if we don't have a value neutral term for cis people, folks do use the word normal. And that actually sets us back because being trans is not an abnormality. It's a normal human variation. It's in fact what I would call a minority trait. And human beings are not very accepting of minority traits, but we are able to learn how to be. For me, the best example of that would be left-handed folks. We have persecuted left-handed people even into my lifetime, but now they're pretty well integrated. And part of that is using neutral language. We say left-handed or right-handed, not left-handed or normal, right? So if it's left-handed or right-handed, it's transgender or cisgender. Next slide. Gender expression is yet another separate trait. It doesn't necessarily connect to your gender, and it doesn't necessarily connect to your biological sex. This is all of the cultural and external stuff that we do. Clothing, hairstyle, speech, gait, gestures, all of the stuff that we do that either does or doesn't conform to our cultural norms and stereotypes around gender. Okay, next slide. Your orientation is the final trait that needs to be separated out here. And this really just describes who you like. It really doesn't have anything to do with your gender or your biological sex. It just tells who you're attracted to. Next slide. So this is kind of in summation. Sex is your body, your chromosomes, hormones, genitals, and gonads. Your designated sex is really just how you got labeled based on your genitalia. Your gender is your own deeply felt internal sense of being a man, a woman, or a non-binary person. Your gender expression is how you do gender on the outside. And you may use your gender expression to disguise your real gender, or you may use your gender expression to actually express your real gender. But we can't tell by looking at you from the outside. And your orientation describes who you're attracted to. Next slide. So one of the most important things that we have to teach folks is that the discrimination and violence that comes towards LGBTQ people is not evenly distributed among LGBTQ people. Intersectional discrimination means that folks who carry more marginalized identity characteristics are going to experience more disparities. So we see this turn up as health disparities for sure, but we also see it just directly in experiences of discrimination and even interpersonal violence. We see that trans folks of color have way worse outcomes than white trans folks. Trans women have way worse outcomes than trans men. And all of that is because of the other systems of oppression that work in our society. It's not just about transphobia, it's also about racism and sexism and all of the other sort of systems of oppression that exist in our country, in our culture. All right, last slide. Here are some things that we suggest you could do to make it better, right? And in a clinical environment, we definitely think it's really important to think about the physical surroundings, think about brochures, posters, stickers, think about the bathroom access for people. You know, I don't think my 7-year-old self thought I would spend so much of my adult professional life talking about where other people get to go to the bathroom, but I guess probably my 7-year-old self thinks it's hilarious that I do. But bathrooms are a really big deal for trans and gender variant people. So think about what your bathrooms look like, how you make sure folks have access, how do you make sure and call people by the name they go by, how do you just continue to educate yourself and, you know, keep taking a look at our internal biases. I know that's a process that I'm in the middle of every single day, and it's not easy, but it's how I'm getting to be more proficient with working with other human beings, is really trying to examine the biases that I carry and figure out how to heal some of that stuff. And we know that education can be a really big part of it. So next slide. You're welcome to contact me through this main email, but I'm also going to drop my email into the chat window over here where it says ask a question. I'm going to pretend like I'm asking a question, but I'm really going to put my contact info. So thank you all so much. Let me put that in there while Jamie takes it from here.
Thank you so much for your presentation, Adrien. It was very comprehensive, and I think we will all leave today with some new tools to help us be more supportive and inclusive for our LGBTQIA+ friends, family, and colleagues. To our attendees,
thank you, Will.
You are so welcome. Thank you. To our attendees, if you have questions that Adrien did not address, or you would like more information on something he shared, go ahead and put your questions in the Q&A box. We will address as many questions as time allows after our next speaker. Dr. Jamie Garfield will present on lung health disparities in the LGBTQIA+ community. Dr. Garfield, the screen is yours.
Okay, thank you, Will. Thank you, Adrien, for that amazing introduction. I am an associate professor of thoracic medicine and surgery at Lewis Katz School of Medicine, Temple University Hospital. I'm also an interventional pulmonologist. I'm interested in lung cancer and lung cancer screening, tobacco use and dependence, and I am a national spokesperson for the American Lung Association. More personally, next slide, please. I am, my pronouns are she, her, and hers. There's a little bit of facts about me to play off Adrien's slide here. I'm an expat New Yorker. I don't remember what's here. I'm a mother of a 10-year-old son and a partner. I love art, all types of art, modern art, contemporary art. I'm an Eagles fan, since Adrien noted that he was a Saints fan. And I identify as queer. So Adrien made a point of mentioning that this word might not be, used commonly, or it's used with care. You know, you need to use this word with care. But I certainly identify as queer, and so you can only know by asking. Next slide, please. So LGBTQ health is very simply supportive and inclusive care for all community members. And this is something that is deeply important to me, and also it's important to my institution. So can you click through to that next part? So the LGBTQ Healthcare Equality Index is an index that's put forth by the Human Rights Campaign, the HRC. And in order to be designated a healthcare equality leader, an institution has to demonstrate excellence in 4 different realms. They have to show that there's foundational elements for LGBTQ patient-centered care. There also has to be support services for LGBTQ people. There needs to be benefits and policies for LGBTQ employers or employees. And finally, there needs to be community and patient outreach. And Temple has made it a priority to be a healthcare equality leader for the last 3 years. We have to get a 100% score on each of these metrics. Another thing that Temple does, and any institution can do this, and I encourage anyone to do this, is that we have a designation for LGBTQ affirming providers. So our providers are able to take an information course or a knowledge gap test assessment, and if we pass it and we've demonstrated that we're interested in caring for the LGBTQ community, we can be designated as an affirming provider. And this is very helpful for people within the community to be able to find this information and assess which providers are going to be informed and educated and sensitive to the unique needs of this population. Next slide, please. So I'm here to talk to you about lung health and the LGBTQ+ community. Of course, there's many diseases that are disparate between this community and the heterosexual community, but I'm going to talk about a few lung diseases. So I will speak about tobacco use and dependence, lung cancer, asthma, and a little bit of asthma and a little bit of COPD. Next slide, please. So why does it matter? Why does it matter that the lungs, the COPD lungs that I'm caring for are in a heterosexual male as opposed to a trans male? And why does it matter that the lung mass that I am caring for, that I'm diagnosing, is in a lesbian woman as opposed to a heterosexual woman? Does it matter? Next slide, please. It absolutely matters. And the reason why it matters is because disparities to care exist all across the continuum of care. So if I'm not mindful of the person in whom these lungs exist or sit, I am not able to be intentional about what this person's risk is for the development of different types of diseases. And I can't appropriately screen for these diseases if I don't know their risk. I may not be able to make the correct diagnosis. I may not be able to initiate the appropriate treatment, or even if I initiate the right treatment, that patient might not be able to follow that treatment regimen that I put in place because I don't know the home that they're going home to. I don't know what kind of support system they have at home if I don't know this person where these lungs are sitting. And ultimately, all of that affects outcome. Next slide, please. So we're stuck in this cycle where these disparities, these healthcare disparities, are perpetuated. And the first part of this cycle, the reason why these disparities exist, is discrimination. And so discrimination is something I wish it wasn't here. And as Adrien mentioned, it's not distributed equally within this community. So trans people are much more likely to be discriminated against than gays and lesbians. And there's a lot of work that we're doing to dispel these discriminatory policies and acts, but there's still a tremendous amount of discrimination in this community. Next sort of issue is that there are barriers to care. So maybe the result of repeated acts of discrimination, trans people may be less reluctant or less willing to go back to providers who made them feel like they weren't valued or they weren't heard. And barriers to care can also mean inadequate insurance, homelessness, substance use disorders. All of these create situations in which it's more difficult for people within this community to get and receive equitable care. The next thing that is really important, and really the reason why we're doing this webinar, is that there is an inadequate education. So there are huge disparities there are huge differences in what a clinician understands about this community and what the community understands about this community. And for example, this reference that I put at the bottom of the screen here was a national study which showed that 78% of clinicians felt that LGBTQ people were unwilling to disclose their sexual orientation and gender minority status, when in fact less than 10% of sexual orientation and gender minorities are uncomfortable or unwilling to disclose their status. And so there's a huge disconnect. And in fact, the office workers in that study were asked, why didn't you ask? Why didn't you ask what this person identified as, what their gender was, what their sexual orientation was? And the office workers said, this is too personal and it's irrelevant to the care of the patient. So that's a big difference in what clinicians and healthcare workers think and what the community actually needs. And the result of this inadequate education is that there's insufficient data. We don't have the right information. The data is inaccurate to be able to make sweeping claims about what this community suffers from in terms of risk and prevalence of diseases. Next slide, please. This slide is from the National LGBT Cancer Network, and the byline, these are called cancer cards, and they have them for a bunch of different cancers, and this byline is tobacco is a queer issue. Cancer is a queer issue. Lung cancer is a queer issue. And then when I first saw this, I remember thinking, is tobacco a queer issue? Is cancer a queer issue? And after really learning more about this and thinking about this more, absolutely tobacco is a queer issue, and absolutely cancer is a queer issue. Let me show you why. Next slide, please. I think Danny mentioned this earlier in the talk that this community has been intentionally targeted for tobacco use. And this is a community of people that have not been targeted for marketing in any other way, but yet they are intentionally and explicitly targeted for tobacco use. So you can see this American Spirit ad and this Camel ad and this Lucky Strike ad are all clearly geared towards LGBTQ plus people. Next slide, please. And this has been going on for decades. So in the mid-1990s, this project called Project Scum, which was put forth by the R.J. Reynolds tobacco companies, essentially it stands for subculture urban marketing, and they targeted gay men in the Castro district of San Francisco. And these were people who were suffering from substance use disorders, homelessness, sometimes AIDS, or HIV, and yet they were intentionally targeted to increase tobacco use in this population. And this is not the only example of this. There's another example where the Philip Morris tobacco companies settled a huge boycott by donating millions of dollars to AIDS research. And in donating that money to AIDS foundations, they gained access, again, to this community to intentionally target this community to increase tobacco use amongst them. Next slide, please. And what is the result of this intentional targeting of marketing towards the LGBTQ community? A lot more LGBTQ people smoke cigarettes compared to heterosexuals. So before I get into the details of this, I want to take a moment to talk about what this data means and what it looks like. So this is the best we've got, right? This is data from the CDC using the National Health and Interview Survey, the NHIS, using data from 2013 and 2018. And the first thing that comes to my attention is they use the word straight. Okay, so I don't like that word. To me, straight means that normal, and that anything that's not straight is crooked or abnormal. And so I would prefer the word heterosexual, but this is, bias that's baked into this data. The second thing that occurs to me is there's this group called something else. It's a huge group, and the error bars on this huge group are really wide. So 95% confidence intervals are extremely wide, meaning that there are either not enough people in this group or there's a lot of difficulties with interpreting what this means. Who's in here? Is this trans people? Is this non-binary people? Are we talking about sexual orientation? Are we talking about biologic sex? And also they have this criteria here, male and female. You only get to be one or the other. So let's say you're a trans man. You're a trans man and you are in a relationship with another man. How do you fill this out? Do you fill this out as a trans person? Do you fill this out as something else? Do you fill it out as a gay person? Do you identify that you're male or that your sex at birth was female? There's no way to know. You're just going to make whatever decision you're going to make. And so how do we use this data? This is the best that we've got. We use this to make all of our decisions about the risk that this community has and the prevalence of disease. It's extremely flawed. So as long as we accept that there's a lot of flaws with this data, let's go over and look at a little bit more about what it shows. So next slide, please. So you can see that the age of smoking initiation for the LGBTQ community is earlier than the heterosexual community, specifically for the women. So the lesbian women and the bisexual females started smoking earlier than heterosexual females. Next slide, please. But that data doesn't include anything about trans people. as we said, they fit into maybe that something else category. And so to look for data on trans people, you have to look at sort of even less accurate data sources. This is an article from Tobacco Prevention and Cessation in 2020 showing that there's an incredibly high percentage of current smokers amongst transgender people, 35.5%. And that, it's alarming that uninsured transgender people are 4 times more likely to smoke than those with insurance. And if you think all transgender people are the same, you're wrong, because trans men were over 3 times more likely to report current cigarette use compared to trans women. Next slide, please. So we just discussed the smoking or the prevalence of adult smokers within the LGBTQ community. But when we look at youth smokers, this cohort of youths have been targeted maybe even more so than the adult LGBTQ people. And this is through the inundation of social media. And so when you look at LGBTQ youth, you can see that more than LGBTQ youth are 2 times as likely as their heterosexual peers to smoke cigarettes. Next slide, please. And as such, it follows that the youth smoking rate for gays and lesbian, bisexuals, and anyone who fits into this not sure is much higher than it is for heterosexual males and females. So you're looking at between 10 and 16% of the LGBTQ people compared to somewhere between 6 and 8% of heterosexuals. Next slide, please. If you look at e-cigarettes, as opposed to traditional combustible cigarettes, you can see again that there are some groups within the LGBTQ community that smoke e-cigarettes to a greater degree than heterosexuals. Particularly, we're talking again about the women. So female lesbians and female bisexuals have a greater rate of e-cigarette use than their heterosexual counterparts. Next slide, please. And when you look at for those who started using cigarettes before age 13, everyone within this community started using it to a greater percentage of them started using cigarettes before age 13 compared to heterosexual, both men and women. Next slide, please. Adrien used this word intersectionality, and I think it's really important to mention this again. So although we know that the LGBTQ community has been targeted for tobacco use, the effect on sub-communities within this community that have other minority statuses is exponential. So although 1 in 4 LGBTQ youth are addicted to nicotine vaping, and still that's too much, you can see that Asian transgender youth are 3.5 times more likely to vape, and that Black transgender youth are 6 times more likely to vape than their heterosexual counterparts. Keep going, please. And that any experiences of homophobia, transphobia, racism, or other forms of discrimination is linked to increased tobacco product use. Next slide, please. It's hard for me to give a talk about tobacco use without talking about tobacco cessation, and I want to just mention that for this community of people, it's difficult for everyone to quit smoking, but it's even more difficult for people within the LGBTQ community to quit, and that is because a lot of providers are insensitive to the additional risks and exposures in the support networks, and maybe lack of access to care or the inability to pay for medications or counseling that this community suffers with that the other heterosexual community does not suffer with. The FDA has not found any e-cigarettes to be safe or effective to help smokers to quit, and that individual phone and group counseling in combination with FDA-approved medications can increase the success of cessation by up to 60%. And tobacco control policies are extremely important in impacting use. And what I mean by tobacco control policies, there's so many different aspects of this, but policies that limit where and when you can smoke and vape, policies that limit how much regulation is placed on smoking and vaping products, how easy it is to get cessation services, how much funding goes into research around and data around the impact of vaping and smoking. All of these are extremely important for impacting use. Next slide, please. Okay, lung cancer. So while cancer registries are horribly lacking in documentation of sexual and gender minority status, we know that tobacco use remains the #1 risk factor for the development of lung cancer. And so we can infer that since the LGBTQ community is more likely to smoke cigarettes, they are also more likely to develop lung cancer. But the data doesn't exist. We don't know actually that lung cancer, the rate of lung cancer is higher in the LGBTQ community, although it certainly is expected to be so. And the risk for lung cancer sort of separate of tobacco use at all. The risk for lung cancer in this community also relates to marginalization, unsafe practices, lack of insurance, and failure to seek or continue care due to discrimination. Next slide, please. So this was a recent infographic put out by the CDC in 2019-2020, which was sort of about COVID, and essentially it carefully looked at the disparities in, or the rates of disease in the LGBTQ community compared to the heterosexual community. And it's kind of a busy slide, but please go to the next slide. It uses a different data set. So the BRFSS from 2017 to 2019. And there's a lot going on here, but you can see that when the CDC took the time to look at the difference in prevalence of all of these different diseases, bisexual minority status versus heterosexual, every single one of these diseases had a higher prevalence rate in the sexual minority community than in the heterosexual community. And this was a huge study. 600,000 people were included, or as a review, 600,000 people, only 25,000 were these sexual minorities. So it was too small of a data set to split this up by gays and lesbians and non-binary people or trans people. So it was grouped all together, but there's still a lot you can understand about this, and it's maybe perhaps in many ways better than the previous data that we looked at from the CDC. Next slide, please. So if we go back to that data, because we're interested in some of these subcategories, we can see that the LGBTQ community is more likely to have ever been diagnosed with asthma than their heterosexual counterparts. Next slide, please. And that particularly, when you look at asthma attacks within the past year, gay men were much more likely to have had an asthma attack in the past year compared to heterosexual men. Next slide, please. And finally, when you look at COPD and you look at this data, there actually is no difference. So there's no difference between the incidence of COPD, those who've been diagnosed with COPD in the LGBTQ community compared to heterosexuals. So either you just take that as face value and you walk away and you say, all right, I guess I don't need to screen my patients for COPD. I don't need spirometry. I don't really need to talk about cigarette smoking. If you're really going to trust this data, you have to know the validity of the data and where it comes from. Next slide, please. Because actually, when you look at that second sort of data set that we talked about from the BRFSS, you can see that heterosexuals, again, they group all sexual minorities here, but heterosexuals had a rate of COPD of 6.9 compared to the sexual minorities who had a rate of COPD of 10.3. And if you look at intersectionality, so you're looking at LGBTQ people or sexual minorities who are Hispanic, the rate is more than 2.5 times the rate of heterosexuals. So again, this just speaks to the importance of understanding the data that you're looking at and being careful of making conclusions without really knowing the validity of where this data comes from. Next slide, please. So Adrien mentioned how to be supportive of this community, and I want to just say how to be a supportive provider and educator. So the idea is to support educational training initiatives and training like this one to improve health professionals' understanding of the LGBTQ community. We want to make sure that health providers and healthcare workers know how to use inclusive language, know how to be respectful in their questioning, and know when to refer for testing and screening where appropriate. We also want to make sure that we make LGBTQIA supporting providers like myself visible and accessible so that people within the community experience less barriers when they are looking for a provider who is sensitive to their needs and has some knowledge about what the disparities to care are. We want to push for accurate documentation in our electronic medical records and adequate and accurate representation in registries and clinical trials, so the data that we can interpret from these clinical trials and statistics are meaningful and reliable to determine clinical care. We want to screen for known LGBTQIA health disparities in our patients and friends. Next slide, please. I think that's all I've got. So please feel free to ask any questions to me or Adrien or anyone else in our webinar.
Thank you so much, Dr. Garfield. That was certainly an in-depth overview. Quite a few questions have been submitted. So Adrien, I'll ask you to unmute. I'd like you to answer first if possible, and Dr. Garfield, please feel free to add your insights as well. And the first question on my list is, what efforts are being made in the medical community to treat LGBTQ+ as individuals?
Are you able to hear me? This is Adrien.
Yes.
Okay, great. You know, there's a lot of different efforts that are going on around the country right now, from you know, trying to get this stuff included as standard in med school curricula, which is really critical. You know, people are able to become doctors without 1 hour of discussion about transgender people, and that's really a hard thing on the trans population in terms of being able to seek care safely. So teaching it would be a great thing to start with, but also one of the things I've seen in our state that's been amazing is we're seeing different hospital systems start to update their electronic medical records to ask better demographic questions of people as they come in the first place. So we're starting to see people's biological sex be tracked separately from their gender, and then also ask them their orientation and their pronouns and their chosen name. So the EMRs are getting more sophisticated, and I think that's also a big part of it. And I'd
Thank
love
you,
to hear what Jamie says too.
I don't know if you wanted me to speak to that as well, but coming from the, you know, from the side of, from the medical side, I wish we were further along than we are. I mean, we do have the ability to enter this data into our electronic medical record, and just because of a lack of awareness and education, even with the best intentions, it's not really being entered as accurately or as inclusively as it should be. And again, I think I hope I made it clear that without this information, we really can't take care of this population. And so we're trying, but it does begin in medical school. It really begins in high school and undergraduate and elementary school education on the importance of accepting this minority variant and nothing more than that.
And Dr. Garfield, what role do we, the general public, have in reducing disparities?
I mean, I think that, we want to be accepting of one another. This is just one example of a group of people that suffers from inequity. So inequity in terms of acknowledgement of their lived experience. I think everyone has a part to play. We have a lot of work to do in the healthcare community, but Adrien's work is phenomenal, and he is going around not just to healthcare providers, but also to communities to just increase awareness and education. So I think the more that we do things like this, the more visible we are, and I appreciate the ALA making this a priority during the month of Pride. I think this is a huge start.
Thank you so much. Adrien, this one is for you. If we are reaching out to someone new via email, like a CEO or a higher up, and we do not know their pronouns, how do we address our emails?
That is such a great question, because I think we are now looking to deconstruct some of this stuff and think about how we use language, especially language that's geared around like formal respect in a way that isn't gendered. And for me, I have to tell y'all, I was raised mainly in Mississippi. I grew up in the South. I was raised to call every single person ma'am or sir. And now I just can't do it because I've seen it hurt people so badly. So for me, what I've learned to do is just start an email with something like, good morning, and then what I want to say, right? If I don't know how to address somebody, then I try not to. I just try not to until we're able to make introductions and I can learn more about them or learn how they want to be talked to and talked about. So I just keep looking for creative ways to just take that out of it if I can, while still being warm and direct and respectful. Thank you.
Dr. Garfield, do you have anything you'd like to add?
I mean, I agree. I have to do the same thing. I mean, it's difficult, when we're rounding, in the hospital on our team, I have to remind myself to say, hey, folks, or hey, friends. I try not to be gendered in the language that I use, both as like a model to my medical students and residents, and just personally because I want to do better every day of being inclusive of people. I think it was really nice that Adrien showed that intersex video, because he can't speak to what it's like to be an intersex person. I can't speak to what it's like to be so many different members of this community. I can only speak to what it's like to be me. And so we have to make it okay to ask, what feels right to you? How do you want to be addressed? And to understand that there's no disrespect in doing that.
Just to follow up on that, I love that you said there's no disrespect in asking. What is the importance of asking someone their pronouns?
I don't mind starting if that's okay.
Yeah, please.
This is Adrien again. So there's two things I want to say. I mean, we have always taught folks that it is okay to ask, and it is okay to ask. But these days we're asking people more often to give your pronouns if you want somebody's pronouns, right? It's easy to come in the room and just say, hi, I'm Adrien, I use he pronouns. And it normalizes the idea that that's just how we introduce ourselves, Plus the fact is, I don't really know you. So you may know that your gender expression matches your gender, which matches your pronouns, but I don't know that. So I actually do need your pronouns anyway so that I know what they are. So we always say the best thing is to put it on your badge, put it on your lanyard, wear a pin, say your pronouns, then it's okay to ask. It's much more okay to ask if you're also giving your pronouns, And if you absolutely have to just ask without offering, that's okay too, but that would be the second choice. And that's the reason why it's important, is because the more we learn about this, the more we learn about non-binary people, and the fact that these things aren't nearly as intertwined as we thought they were, sex, gender expression, they're actually really separate things, then we come to the realization that we can't actually assume about anybody even if they look really stereotypical. So that's why pronouns are factoring in more and more.
And it takes vigilance, right? So when I logged onto this Teams meeting, I said, "Can I change my name in my little box right there?" So it says Jamie Garfield, she, her, and they're like, "Oh, I don't think you can change it because you're supposed to have changed it when you logged into Teams to begin with." So anyway, there's a lot of barriers when you're trying to be inclusive and you want to put your pronouns on your badge, or you want to put it on a pin, or you want to put it out to everyone to see. Sometimes you keep having to come up against walls, and just know that, like, continue to try and continue to push and make this visible so that people who don't feel comfortable leading with their pronouns feel more comfortable to do so.
Yes, thank you so much for saying that. It's hard within the systems. It's really hard. It can be so hard.
Indeed. And Adrien, in your presentation, you mentioned Q can mean queer or questioning, and Dr. Garfield, you identified as queer. Could you speak to that a bit more, Adrien?
Yeah, I also actually use that word for myself because I'm a man and my partner is a woman. So to the world and many people like me would describe themselves as straight, but I grew up in the LGBT community and I value my membership in it, So for me, queer is also the word that I use. And I think really all it is just and we've seen a lot of other reclaimed language over the course of history. So there's a lot of different minority trait groups that have taken language that's been used really offensively and violently against them and started to refer to themselves with that word, because then it starts to change the very nature of the word. It can start to imbue that word with a type of a pride, a shared identity instead of being victimized by it. But also there are other people within the community who will never really like that word, right? I have some really close friends out here who were really abused with the word queer. And for them, it doesn't feel empowering. It feels kind of triggering, and they don't want to call themselves that. So even within a group, a reclaimed word will always be controversial. But for some people, it's a really powerful way to name yourself.
Thank you for sharing that. And my final question is simply this: is it LGBTQ plus or LGBTQIA plus?
Go ahead, Adrien. That's all you.
I would say the answer is yes. It can be either one of those. It's okay. The language, the terminology is ever evolving, even for us, even within the communities. So the language is shifting and changing, and the idea would be that we just try really hard not to use terms that we know are disrespectful or thoughtless. But in terms of the acronyms, there is not a right one. Everybody's doing it differently. And actually, I've started to hear people use SGM to mean sex and gender minorities. And some folks don't like that, but I kind of love it. I think it's really inclusive. We're not trying to always figure out what group is left out and put the letter on. We just know that SGM includes all of us who have a minority trait around sexuality or gender. So
that is a really insight. I'm so grateful that you shared that. And I want to say thank you, Adrien, for your time and expertise today. Dr. Garfield, thank you for presenting this important information. And to our attendees, thank you for the questions and the interaction. As a reminder, I highly encourage you to take time to explore the American Lung Association's free resources and our programs on all things lung health at lung.org. If you would like to go back and review the presentations, you can access the on-demand recorded version at the link in your registration confirmation. We thank you for joining today's webinar, and I want to remind you, you are not just a drop in the ocean. You are the entire ocean in a drop, and your voice makes a difference. So use it compassionately. This concludes our webinar. Thank you, and have a great day.